Okay, fantastic. Hello, good evening, good afternoon, good morning to all of them who joining us today from Europe and United States. My name is Michael Lichtenberg, and it's a pleasure and honor to moderate together with Professor Thomas Zeller from Wissgott today this Serranator webinar on behalf of Cage and Vascular. We will focus today especially on BTK disease, showing you a very interesting new standard of care for BTK lesion preparation, especially. We will have the honor to have Dr. Christian Wissgott as well here and Professor Marianne Brodmann from Graz, who will introduce us to the technology, and especially Christian will show a very interesting cases and show us how important lesion preparation is in the different fields of the vascular bed. So welcome all the attendees here today. Please send us your comments, your remarks for the presentation so we can discuss in between. And we really want to do an open discussion here to discuss a new standard for BTK lesion preparation. Having said this, thank you very much, Thomas, Christian, and Marianne, that you are here. And Professor Brodmann will now start with the first presentation. Marianne.
Yeah, thank you very much, Michael, and thank you for having me in this webinar. I'm going to present some information about the Serranator, which I think is the newest generation of this specialty balloons, which really help us in vessel prep. Sorry for not keeping my video on, but I'm sick at home with some kind of flu infection. So with regard to the Serranator, as you can see here on the first slide, the balloon with regard to the diameter is from 2.5 up to 5 millimeters with regard to diameter. With regard to length, we have it from 40 up to 120. And it's with regard to guide wire compatibility, you can use an 014 or an 018 guide wire. It has these strips on the balloon, as you can see here. Peter Schneider, who was involved in this, and I guess you all know him, involved in the production of this or development of this product, always told to me at the early beginning, it's like putting nails into the walls. And with regard to this, you can create this kind of serrations. Even if you have this kind of profile, it's very easy to bring the Serranator forward also to highly calcified and stenotic lesion in the below the knee space. So with regard to trackability, with regard to crossing profile, this is very comfortable. Can I have the next slide, please? So what is needed to prevent restenosis? And I think this is something we all agree on. It's adequate vessel preparation. In the meantime, we have really come to the conclusion within our community that with regard to adequate vessel preparation, we can enhance and improve our definitive outcomes after endovascular revascularization. We need to open the vessel while avoiding paratrauma, ideally without the stent. We need to remove the disease, remove period to drug uptake, debulk the calcium, and gain the lumen. And it should be a less than 30% residual stenosis, which we would like to achieve before we do the definitive treatment. So what is the unique mechanism of action? We have this point force, Serranate with 1,000 times more point force compared to Boba. We have the stainless steel serration strips. They are effective in all lesions, also in calcified lesions. And what is also very important, a low and slow inflation. So 4 atmospheres for 60 seconds or 6 atmospheres for 60 seconds. So with regard to the mechanism of action, you can see here in a model a cadaver model, the serrations we are able to create with this with this balloon, with these stripes which are embedded on the balloon. And this is the video I'm going to show you here. So once again, you can also see how the Serranator is working, and therefore creating these holes in serrations in the vessel wall. And at the end of the day, this is also relevant for drug uptake. Next slide, please. With regard to optimizing the lumen gain, we were able to achieve in the data we have collected under different evaluations. Freedom from clinically driven TLR at 6 months was 97.7%. With regard to recoil, 89% less average recoil than Bober, and with regard to minimizing the dissection, 1.9% bailout stand rate in the prelude below the knee study. And I think these are really outstanding results. So let me summarize the clinical trial summary data we have so far. We have prospective multicenter core lab educated 100% data monitored data. So prelude above the knee was a first in human study with 25 patients. So final residual stenosis 22.7%. So this is really very much below this required 30%. The maximum pressure at the mean was 8 atmospheres. We had 4% bailout stand rate. So once again, very, very low bailout stand rate, and freedom from clinically driven TLR or TBR was 100% at 6 months. What was also very, the next focus was then the below the knee study. All these studies have been published, as you can see here, in really very well-known journals. Andrew Holden was the PI of these studies. Below the knee, we were treating 53 lesions, final restenosis below the knee, 21.8%, maximum pressure means 6 atmosphere. Once again, a very, very low bailout stand rate of 1.9%, and freedom from clinically driven TLR at 6 months was 97.7%. Next slide. So when we compare Bober versus Serranator, especially in below the knee, we also did a single center core-lab educated BTK sub-analysis, which was about the recoil. 49% improvement in residual stenosis, greater acute luminal gain using the Serranator. This provides increased blood flow, greater volumetric blood flow using the Serranator balloon versus Bober, 2.4 times. And the Serranator outperformed Bober by an even wider margin in the most severe disease. So we had a 62% improvement in residual stenosis in CTO. And we needed only 5 atmospheres as the average pressure compared to 9 atmospheres in the Bober arm. So the force of the Serranator data, a standard balloon versus Serranator, a single center sub-analysis from the preload BTK prospective study, improvement in mean diameter stenosis achieved by Serranator compared to Bober, as you can see here. This is the preload BTK, and this was the 25 lesions of the Bober analysis, which one of my residents did, Katharina Güttel. And the final residual stenosis after Serranator scoring balloon angioplasty in the entire prelude BTK study population in comparison from the available literature from below the knee study. And you can see here once again in green the favorable outcome of the prelude BTK sub-study of the Serranator device. this is a manuscript which is under review, the Serranator in pedal arteries, retrospective multicenter below the ankle. It's a novel study on first specialty balloon use in pedal arteries, 41 vessels, and these are preliminary data. 97% freedom from amputation at 5 months, no perforation, no embolization, no significant dissections. 42% of the patients improved to Rutherford 0, and at 89% wound healing rate at 5 months. The recoil sub-study, 40 lesions, Serranator versus Boba, multicenter below the knee, coilab educated, 6% recoil in the Serranator, 55% recoil in the Boba arm. So once again, this sub-study is showing the significance of a difference this device can make when we do vessel preparation. So with regard to cases, this is a case in a tibial anterior artery. This is the angioplasty before treatment. This is the Serranator inflation. And you can see here the post-treatment angiogram. Next slide, please. Okay, so this was the last slide of my presentation. Thank you very much.
Yeah, thank you very much, Marianne. This was a great presentation about the mechanism of action of this Serranator device, how it works, especially in BTK disease. Of course, mentioning that this device also exists for above the knee interventions. Some technical questions before we maybe dive into the discussion how to treat BTK disease, Marianne. How do you size these devices? This is a typical question I always receive. Do you do a one-to-one balloon vessel sizing, or what is your approach in terms of diameter?
A one-to-one vessel size. This is really the approach we do in our daily practice. And I think this is very important. And even if, I mean, we do it with angiogram. So I think one-to-one is really necessary. I was, I guess we do not, I don't know how much IVUS you use in your daily practice, but in daily practice, it's a little bit, it's not time consuming, but it's very costly. So I think if we would IVUS, then we might have a better view of how the vessel diameter really is. And therefore, if you use it on angiogram, so I think one-to-one is really the most important thing to do.
Thomas, Christian, is this also your opinion? One-to-one sizing is a good way, or do you have different approaches here?
In my opinion, it depends. It depends on, and this would be a follow-up question for Marianne regarding the real indication of this device. It was mentioned that it's a vessel prep system. However, if I look into these data, even if these are single-arm studies, first in men data, but considering that above the knee, there was 100% freedom from reintervention at 6 months, below the knee, it was almost 98%. Question one is this, or was this pure Serranator outcome, or was the Serranator combined with DCB in those two studies, Marianne?
It was a pure Serranator outcome.
So that would mean that the outcome was the Serranator having been used as the definitive treatment, or was POBA?
It was a first in human study. So we used the Serranator as the definitive treatment. It was just the first in human study.
Yeah.
Just to prove the concept of this device.
So,
and that especially below the knee at that time, we didn't have DCP available.
Yeah. Yeah. Well, this is even more I would say supporting the value of this technology, that it serves as a definitive treatment with excellent short-term outcomes. At least it has to be confirmed, obviously, on longer term, meaning at least 1 year follow-up. But it may be that the technology can be even used as a definitive treatment without the need for adding any other kind of treatment modalities.
With regard to this, Thomas, I would agree in the below the knee space for sure, because right now we do not have their drug-eluting balloon working. So I think in the below the knee space, it's an ideal treatment, also as a definitive one, with regard to the data we have seen, and with regard also to the vessel, the balloon lamps which are available, up to 120. So I think this is really a good treatment approach for below the knee.
Another technical question from my side. How many inflations do you recommend with this balloon, considering that there are longitudinal serrations that are performed into the vessel wall? Are you trying to somehow rotate the device after one inflation, or are you done with one single inflation?
In the study we did just per segment where we were applying it one inflation, not rotating it. So this was just what we did in their protocol in the trial. But we did some kind of overlapping. So we were overlapping the balloons when we treated longer lesions.
Similar to a drug-coated balloon.
Correct.
Mm-hmm. But Thomas, would it be interesting to combine this kind of technology together with a anti-proliferative therapy afterwards, just to see if we can enhance long-term patency with a combination therapy? Would this be the next step then?
Yeah, well, basically, I don't believe that the background of your question is whether it would make sense to coat the Serranator balloon with an antiproliferative drug. I would say if we consider the technology as vessel preparation, then probably it would be too costly for treating longer lesions if you would need to use a couple of drug-coated Serranator balloons. So if we consider serration angioplasty as a vessel prep, then I wouldn't coat this device with an anti-proliferative drug, but combining it, of course, with a DCB definitely makes sense, because we have two major mechanisms of restenosis formation to consider. The one is the recoil, and the other one is vessel healing response to injury. And the recoil forces may be or can be potentially overcome by using the Serranator, as shown in the study very elegantly. But the issue of wall healing can be overcome only by applying an anti-proliferative drug. Therefore, of course, my view of the future use of this technology is to combine it with DCB.
Marianne, would you agree, especially in the light of the sirolimus technology? You're one of the PIs of the BTK sirolimus trial. Would be interesting, no?
I think as Thomas has said, I think the easier or how to say it in a good way, the less material I need to unpack during the procedure, the better for me. So if therefore I think if there's some kind of technology out there where you have something which is vessel prep in combination with a drug, I think it would be good to have that, because I think then it makes our daily life a little bit easier.
Yeah, this is definitely good to make our life a little bit easier. Before we come to Christian's presentation in 1-2 minutes, one technical question which comes up here and just received. How far can you go with this device to distal? Can you go to the dorsal pedal or to the plantar artery? Is there
I
any?
mean, I guess it has been shown in the beetle sub-study that we really can go down there until to the foot level.
Do you need to pre-dilate here, or do you can go directly with this device?
Especially below the foot, I would recommend pre-dilatation.
So what I can say is there will be, and this is already approved in the United States, a low-profile Serranator device very soon, hopefully also in Europe available with only 2 serration straps on it. So we can really dive very distal and can even treat the plantar arch here in the future in our dialysis patient with such a technology, which I think would definitely help in these calcified lesion patients. So hopefully we will have this low-profile device also very soon in Europe. Very good. Thank you very much, Marianne, for this presentation and summary of the data. Very important, very impressive. And yeah, let's make it a little bit practice. But before we come to Christian again, if the delegates and attendees here would like to raise any question, please send these questions to the chat. And then we can, of course, discuss this. Christian, give us some practical details, and you're a very experienced Serranator user, so show us some of your great cases.
Okay, thank you very much for your kind introduction. I will share my screen, so hopefully you can see it now. And so the first case, it's a BTK case. There was in the MR angiogram no disease in the iliac arteries, and also we do an antegrade puncture, and there was no disease in the SFA or popliteal artery. And below the knee, we see that there is an occlusion of the anterior tibial artery and also of the posterior tibial artery, and a high-grade stenosis of the peroneal artery. You can also see in the runs so that the flow is not really good. And so the peroneal artery was the only one down to the foot, and which led to reperfusion of the dorsal pedal artery. But the patient had an ulceration, and so we wanted to treat him. And at first we treated the peroneal artery. So we crossed it with the 014 guide wire and treated it then with a Serranator with a 4x40. So my practice now is more in 1-to-1 or some slightly oversizing the Serranator, and this inflation it with 2 atmospheres, and we go slowly higher with 4 atmospheres. It's still a little bit impression of the Serranator, and at 6 atmospheres there was still a little bit, and we waited for a minute, and at the end of the minute with the pressure of 6 atmosphere, we see that the Serranator was fully inflated, and so we could achieve nice result at the peroneal artery. So no rest stenosis, no recoil at the moment. And we wanted to try to recanalize the anterior tibial artery as well. And first we tried an antegrade, which failed, and then we do an retrograde attempt, which also failed after some actions. So we had to stop it, and therefore we could do another angiogram after 60 minutes after the initial serration angioplasty, and you can see there's still no recoil at the patient, and also in the run you can see the flow is much better and there's no recoil, vessel recoil. So the next patient was also with a Rutherford 5 stage with multiple risk factors, and there was also no relevant stenosis at the femoral arteries, but severe disease below the knee. We have an occlusion of the anterior tibial artery, high-grade stenosis of the peroneal artery at this stage, and high-grade stenosis also in the posterior tibial artery, and some stenosis also in the plantar artery. and this also led to a less perfusion of the food. And here again, you can see these stenosis also below the ankle. And again, we started first to cross the stenosis of the peroneal artery and treat it with a 3 by 120 millimeter Serranator, and achieved a nice result of the peroneal artery. After that, we crossed the posterior tibial artery and used the same Serranator, the 3 by 120, and treated the posterior tibial artery proximal, and also we crossed it down to the plantar artery and treated the plantar artery and the distal posterior tibial artery with a 3 by 120. And this is the result proximal. So again, a nice result. And I will show you the foot at the end. And after that, we also crossed the occlusion of the anterior tibial artery using a crossing device. And after full crossing with the 014 guide wire, we used again the Serranator 3 by 120. And this is our final result. So we get a really good perfusion down to the foot, and also the stenosis at the plantar artery is very nice. So again, here also in the running files. And here the foot, so there's no stenosis anymore. So this was, we could treat the complex disease with one balloon. It was very cost saving at this moment. And we achieved a very nice result, and patient gets much better.
So one quick question here,
Yes.
probably to interrupt you. 3 millimeter down into the plantar artery. That means this was definitely somehow oversized according to at least the luminal diameter of the plantar artery. But it didn't seem that there was any negative impact of this oversizing. So there was no dissection, there was no perforation, nothing. So this is a little bit opposite to what Marianne did recommend, a 1-to-1 sizing. So it already during the first case, you did some oversizing, 4 millimeter for peroneal. It's yeah, I would say a little bit ambitious. The outcome, but anyhow, the outcome did confirm what you intended to achieve here, an excellent result. So it seems that your strategy is more going to oversize the Serranator.
Yeah, it depends a little bit on the experience with the IVUS. So that we see that we underestimate the vessels in the angiogram, and so I'm not using the IVUS in every case, but I've learned from it and oversized it a little bit in comparison to the angiogram.
Yeah, I regard that as important. This is a lesson learned from all different kind of balloon-based studies, that slightly oversizing by 0.5 millimeter, sometimes even 1 millimeter, achieves better outcomes as compared to undersizing or 1-to-1 sizing. That's simply what I want to mention here.
Okay. Okay, so I will go on with my third case. And again, it was a patient with no disease at the with relevant stenosis at the SFA or popliteal artery, but with severe disease below the knee. So there were no fully run off. All vessels had some occlusions. The best vessel was still the peroneal artery with short segment occlusions and high-grade stenosis. And we could cross the peroneal artery with the 014 guide wire and used again a 3 millimeter, 3 by 80 Serranator to treat it and achieved these initial result. And we waited another 10 minutes and could see that there's still no recoil in the segment, and we could clearly improve the perfusion of the food.
Was this done without pre-dilatation? Had you been
Yes,
able?
all cases I've showed were done without pre-dilatation.
And that's extraordinary.
And the last case, it's not really spectacular. It's an SFA case. It's an 86-year-old female patient with a Rutherford 3 presenting. The angiogram doesn't look so bad, but at this segment in the femoral papilla area, there's some calcification, and a bit more impressive with the angio run, where you can see that the perfusion is very slow and pulsatile. And again, this segment shows some calcification, and we assume that it might be the area of the problem with stenosis. And we crossed it with the 18 guide wire and treated it then with an 5x40 Serranator. And this is the first image with 2 atmospheres. You can see that the Serranator is still clearly impressed at the segment of calcification. And after a minute, we go up to 4 atmospheres. So it went a little bit less impressed. And again, after a minute, we go up to 6 atmospheres, and there's still a little bit impression of the Serranator, but it's getting clearly better. And in this case, we do also an 8 atmosphere inflation with the Serranator. And after that, we achieve these final results. So in the angiogram, it doesn't look so much better, but it's a little bit smoother, looks a little bit less calcified. But in the runs, you can see that the run is clearly improved. And after that, we done an additional DCB in this segment, and finally could treat this patient without any stent. So this was already my case, some of my case experience, and I would say that the Serranator is some kind of standard therapy in my institute for BTK, and it works very well.
Super. Thank you very much, Christian. Great presentation about your case experience. Very nice cases, especially BTK. And I personally like your, let me say, overstretching idea, overinflation a little bit. So this, I like it. Yeah. Here's the question coming from the audience, from Katrin Gebauer. Is it safe to use Serranator after subintimal passage? So this is a question to the whole group. Does any one of you have experience with that?
Yes, sorry for that. We had some kind of subintimal recanalizations or subintimal passage, and we didn't see in this only a few patients, I guess 2 or something like that, but we didn't see any issues. So I don't know what Christian is thinking of that.
No, I will totally agree. So I think subintimal passage is absolutely no problem. But it's, again, I will probably try to get an intraluminal passage, but there's no risk of perforation or something in subintimal.
Maybe it's even a good idea, then you can work on the media calcification as well with this approach. Yeah.
That's correct.
Yeah. A technical question as well here coming. It's still a 6 French device. So what kind of wire do you use, especially in terms of pushability, trackability point of view?
In most BTK cases, I use the Gladius from Asahi, and normally works very well with this guide wire.
But I guess you think of 018 or 014, or is it just, the name of the device?
It's a 014, and it's also available at a 018, but I normally use for BTK case directly 014 guide wire.
And you did not comment on DCB afterwards, Christian. Are you using DCB after Serranator, or okay, reimbursement is not existing, but would you use it, or do you say it's enough with the Serranator with your experience?
So it's a good question. So above the knee, of course, I use a DCB after the Serranator. And at below the knee cases, it's depends a little bit on the patient history. It's the first time for him. I'm normally try to just keep the treatment with the Serranator as a standalone therapy. But in case of restenosis, I also would complete the intervention with a DCB.
So we need to head-to-head compare and set up a study, Thomas. Huh? Comparing these two different strategies would be nice to have that. Huh?
Yeah.
Who would like to finance that? We'll see. Yeah, but anyway, you know, 3 arms would be great from my point of view. Serranator standalone, Serranator plus DCB, and POA with DCB. 3 arm.
I think it's a good idea, Michael, because it would really help us for finding treatment algorithms, especially in the below the knee space. I think it's really important for below the knee. And I think that would be really good. We have in Europe some kind of DCPs available below the knee, so I think it would be good to do something like that. And it would also help us to close discussions and finalize discussions and come to an end with some kind of discussions. I think it would be good, in my opinion.
Yeah, fully agree. And maybe we can pull up a sign, stop POA. Yeah? And I think this would be a step in the right direction. And yeah, to support this a little bit, I just want to give you a little bit more insights, actually, and then we're coming, I think, to an end of this webinar. Just want to dive a little bit more with some data into the RECORD study. Marianne, you presented already some data. I would like to show some more details. So what we did in this trial is to really compare in 2 centers, Serranator with POBA in the different areas of BTK. And you can see here that the mean lesion length we treated here in these 40 lesions was around 85 millimeter. And after inflation of these 2 devices, we waited 50 minutes based to the protocol Frederick Baumann 10 years ago. Invented waiting 50 minutes and do a re-angio, and this was indeed collab adjudicated to see if there's a difference in terms of dissection recoil after Serranator versus POBA. And here you see some examples of this recoil study here. You can see here in this POBA arm, first image on the left side, pre-procedure, a high-grade stenosis here in the antetip artery, collapse at 73%, lesion length 21. Then we performed standard balloon angioplasty with standard techniques. After this, we achieved, based on collab adjudication, residual stenosis of 32%. And after 50 minutes, we waited 50 minutes, elastic recoil of 100% with a residual stenosis of 77%. So as my colleague here always says, so we were heroes for 50 minutes and then we became losers at the 16th minute after inflation. So back to the roots, actually back to that what we had initial with standard balloon technology. Unfortunately, we don't see this in our daily routine because we're not performing 15 minutes post inflation angios. On the other hand, when we look at here another example from this trial, the Serranator group, you can see here pre-procedural high-grade TP trunk stenosis, which was rated by the collab of 74%. Then we used here 3.0 millimeter Serranator here. Post-inflation, we achieved based on core lab a residual stenosis of 31%. Actually, I don't see 31%, but anyway, this is what the core lab gave back. And the important thing is, after 50 minutes, the elastic recall was only 4%. So huge difference between POBAR and Serranator just on this case example here in terms of that what we discussed and Marianne just presented here. And when we look at the detailed results on outcomes, on core lab adjudication analysis, you can see here the mean recall across all lesions at 50 minutes were rated with the Serranator by 6% and POBAR 55%. So a highly significant difference in terms of this recoil. Interestingly, it's not shown here, no difference in terms of dissection between the Serranator and POBAR arm. This is something interesting, and we can discuss on that. But the recoil is the very interesting aspect. And when we look at the percentage of lesion with recoil defined as more than 10% lumen compromise at 50 minutes, this is actually what Frederick Baumann did in this paper 10 years ago. You can also see here that we really improved this recoil answer with the serration angioplasty. And I think so being a hero even after 50 minutes, I think feels a little bit better than a loser in the 16th minute. So I think a clear answer. And this is what I wanted to show in terms of this dissection, which I mentioned. There was interestingly no difference in terms of dissection between these arms. This was a little bit, yes, more or less surprising. Yeah, but anyway, this is what the core lab found out and was described. So no difference in terms of that. The big difference was the recoil answer. And yeah, maybe one case at the end from our center here. This is also very distal intervention. This is actually around the malleolus in a patient Rutherford 5, only TP. And this is a 30120. Again, I'm also a little bit a fan of oversizing. We used here for 1.5 minutes, inflation 6 atmospheres here, really trying to push lumen. And this is what we had after a minute. Yes, a little bit of oversizing, clearly seen. Good lumen gain, but no dissection. And this was one of the cases we included in the pedal artery study. There was also no recoil after 50 minutes. So also here in this very distal part, no recoil in the plantar artery. So yeah, any ideas about this dissection difference? Why this happened? Has anyone a good explanation? Because I don't have one.
Yeah, well, basically, my experience below the knee is that we rarely see severe dissections with plain balloon angioplasty or DCB angioplasty. So below the knee dissections are not as frequent as above the knee. That's my clinical experience. Therefore, I'm not that much surprised that in this even core lab adjudicated analysis, there was no dissection. The key question is the recoil background. Regarding the study protocol, did you apply any nitro, any vasodilators before you started the waiting period, or was it without?
Without.
So, because the interesting aspect of your first case, you did show the anterior tibial recoil. The recoil was in the area of the former stenosis, and it was distal of this stenosis, simply, I believe, by using a longer balloon. So the key question here is, what's the background of the recoil you had been seeing after these 15 minutes? Is this a kind of functional recoil, meaning is it vasospasm, or is it structural recoil, meaning is it coming from the plaque, so that it's a recoil which will not be reversed even if you would apply vasodilators. That's something, unfortunately, what we had not been able to answer. this question even in this study using the spur, because nobody did use nitro before starting the clock for the 15 minutes waiting period to differentiate between a structural recoil and a functional recoil. And for the long-term outcome, I'm pretty sure that the structural recoil is the key for patency success, and it's not the elastic recoil.
Yeah, I fully agree with that. What I definitely had the impression, also my daily routine, that both recoils are significantly less with the Serranator. Yeah? We see, not always, but we often see these recoil answers after standard balloon angioplasty, which I think is correlated with 10, 12, 20 atmospheres. On the other hand, with the Serranator, we only need 4, 6 atmospheres. Maybe there's something to do with that. So we do not induce so much answer from the artery, from the vessel. But no, next protocol was nitro or prosavazine. Christian, what's your opinion on that? You're muted.
Yeah, it's I think I totally agree to your what you say, that the Serranator would improve both kinds of recoil, the structural and also the functional. Absolutely, it's interesting. Would be interesting to have a study also to treat with nitro. But I think the Serranator works in both kind of mechanisms.
Yep. Marianne, agree? So that we're all on the same page on that?
I agree. I think would be really interesting to prove it. What we think is correct. But I would like to see a proof of that, because we always have some kind of impressions. This is guidance for our other colleagues, and I think it would be good to prove it.
Yeah, agree. And maybe for the next protocols, we include the vasodilators. But as you just mentioned, the spur recoil, Thomas, I think we now have 2 studies really proved that the dedicated specialty balloon is superior than standard balloon angioplasty for this recoil phenomenon. I think this is bringing us to a different therapy approach in the future, I think, and should really think about standard balloon angioplasty as the final treatment in BTK disease, I guess.
Definitely, plain balloon angioplasty is, I would say, somehow a historic kind of treatment, but so far we did not have had better options, at least nothing which has proven benefit over plain balloon angioplasty. What we need is really comparative studies clearly showing this additional benefit also in terms of midterm outcomes, at least at 1 year, that there is a reduced TLR rate, that there is better patency, and hopefully also some clinical benefit for the patient at the end.
Yeah, and I think this is definitely important, and hopefully also some better reimbursement for specialty therapy in the future also. Yeah. But these were great final words, Thomas. Perfect, as usual. Yeah, I would like to thank you after this webinar was great. Was a great discussion. Thank you very much, Christian, for your case presentations, Marianne for the overview of the existing literature, Thomas for great moderation. Was a pleasure. Thank you to 20 delegates which joined today the webinar. Was a pleasure to have you here and discuss also your questions. Thank you very much. Have a great evening, great day. Goodbye.